We couldn't imagine beginning this lecture without you, so thank you. So good afternoon. For those of you that don't know me, my name is Annie Anchalillo. I serve as Director of the Leukemia Lymphoma Program here at Children's National. And on behalf of the Center for Cancer and Blood Disorders, I welcome you to our annual Amanda Toll Lecture. Today is a day for us to honor Amanda Toll, to celebrate the Toll family, and to increase our knowledge about childhood leukemia. Approximately 30 years ago, at the age of 3, Amanda Toll was diagnosed with acute lymphoblastic leukemia, and she was under the superb care of my great mentor, Dr. Gregory Riemann. Amanda did go into remission, but unfortunately she relapsed. After exhausting her treatment, she underwent a bone marrow transplant in Seattle and sadly passed at the age of 6. However, for the past 30 years, her vibrancy and energy continue to live within our institution through the incredible generosity of the Toll Family Educational Fund. This fund has provided support for our Grand Rounds lectures given by world-renowned experts, as well as providing educational benefits for our physicians and nurses. In a short bit, I'm going to introduce this year's lecturer, Dr. Pat Brown, but before I do that, we have a very special gift, I feel, for Amanda's parents. Jeff?
We were recently renovating our office space, and we came across an old photo of Amanda that was put together in 1992 when this fund was established, and it's very touching. I hadn't seen this before, but I just wanted to share this with this whole family. This is Amanda. You remember? Oh, I have.
Thank you, Jeff. So it's my great pleasure to introduce this year's Amanda Toll lecturer, Dr. Patrick Brown. Dr. Brown is Associate Professor of Pediatrics and Oncology at the Johns Hopkins University School of Medicine. In addition, he serves as Director of the Pediatric Leukemia Lymphoma Program at Hopkins Kimmel Cancer Center. Dr. Brown received his medical degree at the Medical University of South Carolina. Subsequently, he completed his pediatric residency and fellowship in pediatric hematology oncology at Johns Hopkins University School of Medicine. Dr. Brown's research has been focused on developing new therapies for childhood leukemia as a standard treatment for child leukemia, both intensive chemotherapy and in some cases bone marrow transplantation, as you know, cause significant acute and late complications. Recent advances in our field have enabled the discovery of genetic changes and subsequent drugs which can target these mutated genetic pathways. Ultimately, these drugs have the potential to be more effective and less toxic than our standard treatments. Dr. Brown's research has contributed greatly to the discovery of a gene called FLT3 found in types of childhood leukemia with low cure rates. He has identified promising combinations of standard chemotherapy drugs and FLT3 inhibitors that can work together to more effectively kill leukemia cells. Dr. Brown has led the first clinical trials of FLT3 inhibitors combined with chemotherapy in children with leukemia through the Children's Oncology Group International Consortium. Within the Children's Oncology Group, Dr. Brown has several leadership positions. Currently, he's chairing the relapse leukemia section. Presently, Dr. Brown is conducting a pivotal phase 3 trial investigating the safety, efficacy, and tolerability of Blinatumomab, an antibody that targets CD19 antigen patients with relapsed precursor leukemia. It is my distinct pleasure now to introduce you to my dear colleague and internationally recognized expert in childhood leukemia, Dr. Patrick Brown.
Well, thanks so much, Ann and Jeff, for the invitation. It's a real honor to be here with the Toll family for the Amanda Toll Lecture. I can't imagine a more honored position to be in, to be invited for this lecture in particular. So I'm going to talk a little bit about the immunotherapy revolution, if you will, in childhood ALL this morning. I think it's particularly appropriate given the history that Amanda went through, that we've finally reached a point where I think we're at the cusp of kind of a brand new era for this disease. So a few things that I'd like to accomplish this afternoon is to discuss the current indications for different immunotherapeutic approaches in pediatric ALL. Importantly, these are not without their own unique adverse events, so it's important to understand what those are and how best to manage them. And then also, they're not without their own mechanisms of resistance. No therapy as yet in cancer has been able to avoid these mechanisms of resistance, and this is no exception. And so it's important to understand what those are and how to optimize the therapy to overcome them. So just a brief overview of leukemia. So leukemia arises when our hematopoietic precursors go awry and undergo a clonal increase. Leukemia itself is classified according to two things. One is the timing of the disease progression and the maturity of the leukemia cells, where acute leukemias are rapidly progressing and are blocked at a very early stage of differentiation, where chronic leukemias are relatively indolent and the cells retain the ability to differentiate. And then by the cell of origin, whether they're lymphoid or myeloid. And so that gives us the four major types of leukemia. I'm going to focus today on acute lymphoblastic leukemia. So ALL is primarily a childhood disease, but occurs across the age spectrum. Overall, there's about 7,000 new cases in the U.S. per year and about 1,400 deaths. So it's not a common cancer overall in humans, but it's by far the most common thing that we see in childhood cancer, accounting for 30% of the cases. Among childhood leukemia, ALL is 80% of those, and of those, 85% B lineage ALL. So B lineage ALL is the primary disease that occurs in childhood. ALL is actually the least common of the four major leukemias in adults. It's only 15 to 20%, and of those, 70% are B-ALL and 30% are T-cell. And so overall, the median age of diagnosis is 15 years, but there's really a peak, as you can see in the Sear curve, at around the age of 3, very similar to how Amanda presented. So what happens in ALL is normally our lymphoid precursors differentiate into lymphocytes, and that's a normal lymphocyte sitting right there. It's about a little bit bigger than a red cell, has a very condensed nucleus with very little cytoplasm. In ALL, the precursors called blasts differentiate and accumulate abnormally in the blood, bone marrow, and other organs. And that's shown in the micrograph on the bottom. So we subclassify ALL based on its cell of origin, as I mentioned, T cell versus B cell, and then also by genetic characteristics. So for example, the Philadelphia chromosome, which is the fusion of two genes, BCR and ABL1, is a relatively common thing, more in adults than kids, but occurs in both. And we would classify ALL as either Ph positive, as having that fusion, versus negative, for example. And there's other genetic features that have been identified, but that's probably the one that's the most commonly understood. So cure rates for ALL have improved dramatically over the decades, and especially in children, but increasingly in adults as well. And the reasons for this are really threefold. First of all, there's been an optimization of our upfront chemotherapy regimens. Secondly, we've gotten smarter about risk stratification. So whereas back in the 70s or 80s, when combination chemotherapy was first being developed, basically all kids were kind of pushed to the limit in terms of toxicity. And there was not really a recognition that some children could be cured with relatively less intensive care therapy, while others really required that intensity. And that's the process of risk stratification that really has been refined in the last number of years. Probably the most important feature of risk stratification currently is the use of minimal residual disease testing, or MRD testing. So we can tell relatively early in the treatment process using these MRD assays based on how much disease is left after, say, a month of therapy or 3 months of therapy, how that affects a patient's risk of relapse subsequently, and we can intensify or de-intensify therapy accordingly. Now, what I'll be talking the rest of the time about is trying to get away from that overall strategy of simply using one hammer of different sizes and intensity to try to treat childhood ALL, but actually moving on to using more targeted therapies. And I won't have time to talk about small molecule targeting of individual signaling pathways today. What I'll focus today is on targeting based on protein expression on the surface, so-called immunotherapy. And so with our current treatment paradigms, the cure rate for ALL overall is about 80% in children and about 40% in adults. And that's, I think, I would argue that that's with the very best we can do with the drugs that we've had for 50 years. including bone marrow transplant. And now the time is to increase those cure rates even further using immunotherapies and other therapies and potentially even reduce the toxicity while we're doing it. And that's what I'll be talking about for the rest of the time. So our current diagnosis treatment of ALL goes a little bit like this. We do a bone marrow test, and the diagnosis is made when we find greater than 20% lymphoblasts in the bone marrow. The risk stratification, as I mentioned, is a combination of clinical, molecular, and early response features, and then the initial treatment is given. That includes, for all patients, central nervous system prophylaxis and treatment, and then a series of combination chemotherapy regimens, starting with the first month of induction, a couple of months of consolidation, and then finally a maintenance phase. Now, what I've mentioned here is that plus or minus TKI, that stands for tyrosine kinase inhibitors. So I mentioned pH-positive ALL. One of the major advances in our field has been to add a small molecule called Gleevec, or there's others called dasatinib or nilotinib, to standard chemotherapy for that subset. And that's really made a huge difference in outcomes for those patients. So for those patients that have a molecular lesion that can be targeted with a TKI, that is added for those patients. And that's either pH-positive or a more recently identified subset called pH-like, which has other kinase fusions. Now, interestingly, allogeneic stem cell transplant is something that has been, that is used primarily, it's used much more commonly in adult ALL than in pediatric ALL, although there are subsets of pediatric ALL where the outcomes with standard chemotherapy and maintenance are so poor, the expected outcome that allo transplant is often indicated in first remission. Now, there's very scant evidence that allo transplant in first remission in those high-risk subsets actually improves outcome over what we anticipate with chemotherapy alone, but because the chemotherapy alone is associated with very high relapse rates, it's something that we typically offer to patients. Now, patients who are relapsed or refractory to treatment, we used to have really nothing more to offer other than reinduction chemotherapy and allo transplant, the same things we would potentially use up front. And what's changed is that we now have these immunotherapies that have entered the stream. And that's what I'll be discussing the rest of the time. So I hope relapse and refractory disease in ALL is really an awful situation for us to manage. And Amanda's case, unfortunately, is still not atypical today. The overall survival after relapse, if the duration of the first remission has been less than 3 years, is really dismal, down in the 10 to 20% range. The only exception of patients that have a decent chance of being cured with relapsed ALL, and this is childhood disease, is if they have a relatively late relapse. The biology of that seems to be a little bit different, but still, these are not very good survival curves, and clearly we need to do something different. So why immunotherapy? Well, it turns out that there are antigens expressed on the surface of normal lymphocyte precursors and ALL that can be targeted with immunotherapy. And so the three main targets that I'll be discussing are CD19, CD20, and CD22. So these are surface proteins expressed throughout normal B-cell ontogeny, which is shown here. And I've listed there kind of where within the B-cell ontogeny that these antigens are expressed. And in the blue boxes are the different lymphoid malignancies that arise from these precursors within normal B-cell ontogeny. And you can see that ALL arises from a relatively early precursor, but tends to express all of these surface proteins. So these surface proteins, fortunately, are not expressed on bone marrow stem cells or other tissues, and so they can be targeted without inducing a bone marrow aplasia, and they can be targeted without inducing damage to non-hematopoietic tissue. And that's different than a lot of other diseases, and one of the reasons why this particular disease has been so amenable to immunotherapy, whereas other cancers have been less amenable. The other thing that's really important to understand is that the complete loss of our normal B cells, at least for a limited period of time, is tolerable. We can replace the function of B cells, which is to produce antibodies, by infusing intravenous immune globulin or subcutaneous immune globulin periodically to the patient. And again, that's different than T-cell ALL, for example. If you eradicate every T-cell in the body, then that gives a patient a severe immune deficiency that's very difficult to live with. But with B cells, you can kind of get away with it. And so what I'm giving you a preview of is the success I'm about to show you with immunotherapy in B-ALL is something that's going to be very difficult to replicate in other cancers because the antigens expressed on B-ALL tend to be expressed in a pretty limited compartment. That's not true of some other cancers. And we can live without the normal component, the normal counterpart of this cancer. And that's not true of many cancers as well. And so while I'm going to now show you what's so promising about this, I want to be a little bit careful and temper the enthusiasm that immunotherapy is going to be the answer for all cancers in childhood or in general. Okay, so what immunotherapies do we actually have for B lineage ALL? There are two main classes. There are antibody-based and cellular-based. And so the antibody-based are shown here. There's a monoclonal antibody that people are probably pretty familiar with called rituximab, which targets CD20. There's inotuzumab, which I'll talk more about. This is a CD22 antibody that's conjugated to calicheamicin, which is a toxin. And then there's blinatumomab, which is a BiTE antibody. And then on the bottom, the cellular therapies are CAR T cells, chimeric antigen receptor T cells. The ones that are currently most in use are single antigen targeted, either CD19 most commonly or coming along as CD22. What we're trying to study in the future would be multi-antigen targeting, and I'll talk at the end about why that's important. So the ADCs of immunotherapy are antibody drug conjugates, BiTE antibodies, and CAR T cells, and that's what we'll be talking about. Okay, so to start with the ADCs, so inotuzumab is the example. You may have heard of Mylotarg, which is an antibody drug conjugate used in AML, and that targets the surface protein CD33 with calicheamicin. This is so-called Lymphotarg. So this is the same type of antibody preparation, but used for lymphoid malignancies. And let's see if I can make it work. Okay, so CD22 antibody is linked to the calicheamicin, which is shown here in the yellow. When that binds to the CD22 on the surface, that antibody conjugate is taken up into the cell, the calicheamicin is cleaved off, and that's just a general cytotoxic poison. And so that calicheamicin then induces apoptosis in the cell. By linking it to the antibody, the calicheamicin is not active until it's in the cell and cleaved off. And so it really targets that calicheamicin to the CD22 positive cell. Now, there is some leakage of calicheamicin out of the cells as they die, and that's what accounts for some of the toxicity of inotuzumab. And I'll talk about that in a moment. So it's important to understand that this mechanism is T-cell independent. So this is a direct target killing by the antibody and the calicheamicin. And it's very easy to give. It's given as a 1-hour infusion once a week. And so you'll see that contrasted with the next two immunotherapies in terms of ease of administration. So blinatumomab, this is the BiTE antibody. So BiTE stands for bispecific T-cell engager. So what that means is this is the actual product. There's a part of the antibody product that binds the tumor antigen, in this case CD19, and there's a part of the antibody product that binds CD3 on T cells. And so it's bispecific, 19 and 3 in this case, and it engages T cells with tumor cells. That's where BiTE comes from. So a couple of the features. So this allows any T cell to become tumor specific by linking the tumor and a T cell, and that is happening regardless of the T cell receptor specificity. So this product can engage any T cell regardless of what the T cell receptor specificity is for that T cell. The other thing that's important is that this does not require the typical MHC class 1 or peptide to be presented to the T cell from the tumor cell. So this basically takes the T cell receptor and the MHC out of it. Any CD3 cell that's in the region of the tumor cell can be engaged and can be induced to undergo cytotoxicity with the tumor cell. Now, importantly, this relies on a functional endogenous cytotoxic T cell response, right? And this is one of the main mechanisms of resistance to blinatumomab. If a patient has been given lots of chemotherapy just before they get this product and their T cells have been poisoned or weakened by that, then they may not be able to respond to this. And so I want you to keep that in mind. It's also logistically difficult. So it's a 28-day continuous IV infusion. It's got a very short half-life. And so what we currently have is the ability to change the IV infusion bags out every 4 to 7 days, but a patient has to kind of carry this stuff with them for the entire month, and that's a single cycle. Now, importantly, this has been feasible in about 160 different institutions throughout the U.S. in the clinical trial that I'll tell you a little bit about. So it's feasible, but it's no joke in terms of logistics. And then finally, the C, CAR T cells. So what's so fascinating about this therapy is that it really is the first example of an intersection of 3 different major technologies that have been kind of in parallel developing. And it's a cellular therapy, which is like a transplant or an adoptive T-cell therapy, of which many of you here are very familiar. It's a gene therapy because it actually changes the genome of the T-cells in order to express a new chimeric protein. And then it's an immunotherapy. It harnesses the power of our immune system. So this is really the first example of a therapy that brings all 3 of these technologies to bear. And so the CAR T cells that we'll be talking about are an autologous immunotherapy. What that means is that they start and finish with an individual patient. They don't require a third party. And so the way this works is, here's the patient. They undergo leukapheresis, which is basically just the collection of their mononuclear cells in which the T cells are there. And what we're after is their normal T cells. We're after their, in the leukapheresis, we collect the cells that contain their normal T cells. Those are sent off to the manufacturing facility where the T cells are enriched and activated. They're transduced with usually a modified HIV virus or retrovirus to put the chimeric antigen receptor gene into the T cells so that the chimeric antigen protein can be expressed. And then they're expanded, put into the final formulation, tested for safety, frozen, and sent back to the site. At the site, they're thawed and administered at the bedside just like any transfusion. So that's the whole process of how it works. What does the timeline look like? Well, it's kind of extended, and this is one of the major challenges with this therapy. So we identify a patient, they undergo leukapheresis, and then essentially there's about a 3-week period at a minimum between when we collect the patient's T cells and when they can start the 4 to 5 days of chemotherapy that we give just prior to infusing the CAR T cells. So this bridging period can be really challenging, you can imagine. If we've got a patient who's got relapsed refractory disease and it's rapidly progressive and they've become resistant to chemotherapy, this bridging can be very challenging. But as I'll show you the data, it has been addressable in most patients. After they receive their CAR T cell infusion, we typically will keep our patients in the hospital for 7 to 10 days because this is really where the majority of the serious toxicities can occur. And I'll talk about what those toxicities are and how we manage them. And then they go through a follow-up period. This is all outpatient, and then they get their first tumor assessment on day 30. And as I'll show you, the vast majority of patients are in very deep remissions by day 30 after this therapy. All right, so as you can imagine, this process of CAR T cells, talk about logistically challenging, involves lots of different people. And it took us probably about 6 months from start to finish to get it up and running. We've been, our CAR T cell program at Hopkins has been running for about a year. We're treating our 12th patient this week. And it has required the involvement of lots of people. I know that Children's National is in the process of opening their CAR T cell program as well. And I'm sure are facing some of the same challenges that we went through. So how does this product actually work once it's made? So I want to point out a couple of points about it. So this is the chimeric antigen receptor construct that is transduced the genetics into the nucleus, and then that gets translated into the protein that's expressed on the surface of the CAR T cell. Now, the native T cell receptor that existed on the T cell is still there. So what you end up with is a big mix, a polyclonal mix of normal T cells that are specific for lots of different antigens that are all forced to be specific for one antigen, and that's CD19. And that's the way this works. It takes a mix of T cells that can be targeting any antigen, flu virus, rhinovirus, et cetera, and makes them all into CD19 killers. And it does it, what turns it into a killer is this co-stimulatory domain. The major technological advance that turned this therapy from an idea, which it was 30 years ago, to a therapy, which it is now, is a series of experiments that tried different co-stimulatory domains. Just engaging the external part, which is the CD19 part, isn't enough. In order for the T cells to proliferate and activate enough that they can eradicate the tumor, you really need these co-stimulatory domains. And there's two major co-stimulatory domains that have been developed, 4-1BB and CD28. The details aren't important. What's important is that clinically, these two co-stimulatory domains are associated with different kinetics of CAR T cell response. The CD28 CAR T cells have a very rapid, potent activation, but they don't last very long. They only last for about 4 months. And so in general, these CAR T cell products can be used to put a patient in remission, but not necessarily keep them there. Patients typically will require additional therapy, most commonly a transplant. The 4-1BB have a slower burn rate, but can persist for a long period of time. There are patients that are now 5, 6, up to 7 years out, having received a single 4-1BB CAR T cell product without subsequent transplant. So I'll get back to that co-stim domain in a bit, but I just wanted you to understand that there's a few different components that are important to CAR T cells. There's the CD19 recognition site, but probably the most important is this co-stimulatory domain. So just to compare CAR T cells versus the BiTEs. The T cells, CAR T cells are genetically engineered to express a CAR. This is our normal T cell. This is the CAR cell. It doesn't rely on MHC or peptide, and that's very similar to Blinatumomab. It doesn't rely on MHC or peptide. The main difference is that one of them provides the T cell function, CAR T cells. The other one relies on our own internal endogenous T cell function. Okay? That's a really important point, that the Blinatumomab is an off-the-shelf drug, relatively easy. You can order it and give it the same day in pharmacy, but the patient has to have endogenously functional cytotoxic T cells in order to respond to it. Whereas the CAR T cells, there's a more difficult process, but it provides that T cell function. Okay, so do these things work? Obviously, I'm up here talking to you because they do. And these are the response rates that have been seen in the major clinical trials with the 3 immunotherapies we're talking about. So CR is complete response, complete remission. That means that the patient has less than 5% lymphoblasts in their bone marrow and has been able to recover normal hematopoietic recovery. This is that you look under the microscope and you can't see leukemia anymore. MRD negative is a really deep remission. That means that you can't detect any leukemia with very sensitive tests down to 1 in 10,000 cells or 1 in 100,000 cells. And so these rates of MRD negative remissions with a single agent in highly refractory relapsed ALL were unprecedented. And so when Blinatumomab these results were first seen, 1 in 3 patients achieving an MRD negative remission in this setting was unprecedented. Now, you can imagine the excitement then when these results became available. For Inotuzumab, it's basically double that. And then for CAR T cells, this is called TISA, we call it T-cell but no one can pronounce that, so TISA, 81% MRD negative remissions. Again, this is why the field went a little bit crazy for this, because this is completely unprecedented. All we had before was very toxic chemotherapy that resulted in remission rates of 20 to 30%, none of which were MRD. So you can see this was a leap forward for this patient population. Now, the question is, though, did it extend survival? And for the first 2, the answer was no. And for the third one, the answer is maybe. Right? So these are the survival curves. This is a large adult phase 3 study of Blinatumomab. And what you can see is that there's an early increase in survival on this Kaplan-Meier curve, but it's not durable. The same is essentially true of Inotuzumab. So you see this, early extension of survival, and then, maybe some improvement down here, but still dismal long-term survival. And this is where CAR T cells really seem to be different. So this is event-free and overall survival for T-cell lymphoblastic. This is in relapsed refractory pediatric patients. And what is clear is that the survival benefit is more durable. Long-term survival appears to be in the 50% range, long-term event-free survival. What that means is that's cure rate. All right, so I've just come back from the ASH meeting where Steve Grupp and Shannon Maude presented the longer-term data from this study, and it appears that of the 120 or 130 patients that have been treated, half of them remain in a long-term remission, at least 18 months or 2 years out, without having had a subsequent transplant. Now, that means half aren't there. And the other half that aren't there, it's either because their CAR T cells didn't engraft or because they developed a CD19 negative escape of their leukemia. I'll talk about that more later, but the point is that half of patients in this setting can potentially be cured, and that is 5 times at least better than what we've been able to achieve in the past with standard therapy and transplant. All right, so what are the adverse events? Because the Blinatumomab and the CAR T cells essentially do the same thing downstream, they activate a cytotoxic T cell response, the adverse events associated with that are the same for those two products essentially. And so I'll talk about those together in a moment. I want to talk about the unique toxicity of inotuzumab first. So inotuzumab, remember, is the one that's an antibody-drug conjugate, doesn't rely on our endogenous T cell function and doesn't provide exogenous T cells. It just basically directs a poison to the cells. That poison can leak, and that leaked poison can damage the liver, and that causes hepatotoxicity. So the main toxicity of inotuzumab is liver toxicity. Where that's a problem is when the patient either recently has been transplanted or subsequently is transplanted relatively quickly. That's been associated with very high rates of potentially life-threatening hepatotoxicity called VOD or sinusoidal obstructive syndrome, a very severe liver toxicity. So while inotuzumab's response rates are great, where we are potentially a little bit limited is that in order to cure a patient after inotuzumab, you really need a transplant, and it may be difficult to combine this therapy with the potentially curative therapies. That's one of the real limitations potentially of inotuzumab. All right, so moving on to CAR T cells and Blinatumomab. Again, I'm going to group them together for the purposes of toxicities because they work by the same basic mechanism and cause the same basic toxicities. And those are CRS, which stands for cytokine release syndrome, and neurologic toxicity. So cytokine release syndrome is essentially what happens when T cells are activated and start to release all of the chemicals that T cells release when they're killing a cell. So it's the same things that cause you to feel like crap when you have the flu. You get a flu virus, your T cells that are specific for the flu get activated, and they start releasing all kinds of chemicals as they're killing the flu-infected cells. IL-1, tumor necrosis factors, IL-6, interleukins and cytokines get released, and that causes symptoms, fever, it causes hypotension, respiratory distress, even coagulopathy. So this is no different than the flu. It's just a very severe flu without being infected. And so it's basically the same thing as T cells being activated by the infection, but they're activated by the tumor in this case. And that's what cytokine release syndrome is. The timing of cytokine release correlates with the activation of T cells. So for CAR T cells, it correlates with CAR T cell expansion, which typically occurs within the first week. With Blinatumomab, it correlates with the ability of the Blinatumomab, the antibody, to engage T cells. And again, that typically occurs within the first couple of days. So the risk period for cytokine release is very early after immunotherapy. The neurotoxicity is also cytokine mediated, but has a different timeline and also has a really different mechanism that is, to date, pretty mysterious. And what I mean by that is you can have patients that have severe cytokine release, but have little or no neurotoxicity, and vice versa. And the timing of the neurotoxicity, as I mentioned, is a little bit later. How does it present? Most commonly, it presents with encephalopathic symptoms. So the patients will become acutely confused. They may have dysphagia or aphasia, and they can also present with seizures. So patients that receive these therapies typically will receive seizure prophylaxis. Now, the good news about the neurotoxicity is that if you wait it out, it has been 100% reversible with the CAR T cell products and the Blinatumomab that we're talking about today. In adults with lymphoma, there has been some more profound neurotoxicities, but in our experience, it's been reversible. So how do we manage this? Well, first of all, the incidence rates. So cytokine release syndrome, the rates after Blinatumomab and CAR T cells vary from 40% to 80%. So it's really common. very serious cytokine release syndrome that might require pressors or PICU is up to 20 to 40%. But what I'll tell you is that we've made great strides in managing this with the use of antibodies that target some of the cytokines, and I'll talk about that in a moment. The rates of neurotoxicity are in general lower, 10 to 30%, and fewer of them are serious, but it does happen. I mentioned that CRS and neurotoxicity may not correlate with each other. To manage the CRS, we give IV fluids, and then the antibody that I was just referring to is called tocilizumab. This has been a game changer. Early use of tocilizumab in cytokine release has prevented the vast majority of patients to get to the point where they need pressors or need to go to the intensive care unit. Only later on, in a refractory patient to toci, will we use steroids. You can imagine why that might be. Using steroids, which can poison T cells in a patient where you're relying on their T cell function, can counteract the efficacy of the therapy. And so the toci has been great as a steroid-sparing agent. The neurotoxicity, as I mentioned, is self-limiting and reversible. The only therapy that really works for it is steroids. And so usually we wait it out, and if the patient really needs steroids, then we use them. Now, the advantage is that by the time the patient develops neurotoxicity, they're usually relatively late after the therapy, and poisoning their T cells is not that bad. Typically, the T cells have already expanded, and the steroids don't have an effect. Tocilizumab is not effective for the neurotoxicity. And this is interesting. So the IL-6 that's produced can cross the blood-brain barrier, but the tocilizumab can't. And in some cases, tocilizumab appears to enhance the neurotoxicity. And what it might do is be blocking the IL-6 that's outside the CNS and allow more IL-6 levels to get into the CNS. And so it's very interesting that once you use tocilizumab, sometimes you see more neurotoxicity. All right, all of these data that I just presented to you are patients that have bulk leukemia at the time that they're treated with the immunotherapies. One of the things that we're starting to introduce is trying to move these therapies earlier in therapy when patients have less bulk disease. And when we do that, the incidence of the cytokine release syndrome goes way down. And that should make sense. If there's less tumor, there's less T cell activation, there's less cytokine release. What's very interesting, though, is that the neurotoxicity incidence has not decreased in that setting. And so, again, the mechanism of the neurotoxicity is different, and we don't yet really understand what's causing that. All right, so we give these therapies, and they eradicate every B cell in the body. These are not tumor-specific or even tumor-selective therapies. They will destroy every cell in the body that has CD19 on it or CD22 on it, and that's all of your B cells. Now, as I mentioned, the job of your B cells is to make antibodies. Luckily, we can replace the function of those with IVIG. Now, that's a big deal, though, right? If you're talking about someone who gets CAR T cells and then they persist for 6 or 7 years or maybe even for life, then you're talking about IVIG administration for life. And we don't know yet what that's going to mean in terms of long-term toxicity. So that's one of the real important questions that we need to answer in the field. Okay, so where do these drugs stand in terms of commercial development? So all three have been FDA indicated for ALL, slightly different indications. So for the Blinatumomab, it's indicated for both adult and pediatric relapsed and refractory disease, but also for MRD positive ALL after receiving chemotherapy. I'll talk about the data for that. That's really important. This is the only one that's been approved for patients who receive chemotherapy, have detectable disease at very small levels. They can receive this immunotherapy on FDA label, and that's adults and pediatrics. Inotuzumab has only been approved for adults with relapsed refractory disease, no pediatric approval yet. And then the CAR T cells, the TISA, has been approved only in children and young adults up to age 26, no adult approval yet. And currently only for refractory or second or greater relapse. Right? So keep those FDA indications in mind. And I'm just going to show one of the things that I've gotten involved with is the NCCN, which is the National Consortium of Cancer Centers, and we put together the very first adult ALL guideline. You may wonder why they asked the pediatric oncologist to get involved, because we do better with ALL therapy than our adult colleagues do. And so a lot of the lessons that we learn in pediatrics can be applied on the adult side. So in the NCCN guidelines, this is where the immunotherapies are. For both pH positive and pH negative ALL, these are now considered standard of care for relapsed and refractory disease, which is a really exciting development. Okay, I want to talk briefly about blinatumomab in MRD positive disease. So remember, what we're talking about here is a patient gets treated up front or gets treated at the time of relapse, and after the first month or two of therapy, you can still detect small numbers of leukemia. And so a study was done in an effort to try to clear that MRD before patients went to transplant. And this was done in adults. It was a global study. 116 patients were involved. They needed to have MRD at levels of 1 in 1,000 or greater. And about 2/3 of the patients were receiving it in first remission. In other words, they received their upfront therapy, they were in morphologic remission, but they still had MRD. And about 1/3 were in their second or third remission. In other words, they had been treated at relapse in that situation. 80% of these patients cleared their MRD after one cycle of therapy. So it's got the ability to clear MRD. And the question was, would that correlate with better survival? And the answer was clearly yes. So in red are the 80% of patients that were complete responders. In other words, they cleared their MRD. And in the blue dotted line are the patients who didn't clear their MRD. Now, the vast majority of these patients went to transplant after this. But compared to historical controls of adults treated with chemotherapy and then going to transplant, this was a 5-fold improvement in overall survival. A pretty incredible increase in survival. And so that's the basis of the FDA approval. Now, only 2/3 actually proceeded to transplant. 1/3 of patients weren't able to proceed to transplant after receiving blinatumomab, and of those, a significant percentage remained in prolonged remission and still remain in prolonged remission. So is it possible that blinatumomab in the setting, in the MRD setting, could potentially be curative without a transplant? It's possible, but we're going to need more studies to see that. On the other side, of the 74 patients who did go to transplant, 20 of them died of transplant-related mortality. So in general, the post-blinatumomab transplant did not improve survival. If anything, survival was less with transplant. So one of the big unanswered questions is how best to treat patients after they receive the immunotherapy. Should they go to transplant? Should they not go to transplant? These are data that we still need to develop. Okay, and so just to prove that I was excited about this, they asked me to write a commentary in the journal that it was published in, and again, a 5-fold increase in overall survival in a relapsed refractory setting is really kind of unprecedented. So both CAR T cells and the blinatumomab have had these increases in survival of patients that really are out of standard options that have been really something that is changing our field. It really is a paradigm shift. All right, so as a result of that study, blinatumomab is now also in the NCCN guidelines for MRD positive disease. These are patients in remission after upfront therapy. This is the first immunotherapy to be approved for upfront treatment of ALL, so it's very exciting. Okay, so now downsides. This stuff is expensive. All right, so look at these price tags. $500,000 for CAR T cells. Basically $200,000 for a month or two of the other two therapies, right? So this is a big deal. And the other thing about CAR T cells is that you can't just order it from your pharmacy. This is only available at a very small number of designated centers. And so access and cost are huge issues. And I'm not going to be able to address all of those here. I will simply say that the drug companies that have developed these therapies have done the best they can to try to help set up programs to address some of the financial toxicity associated with these therapies. But the real challenge in the long term that we're seeing is that hospitals lose money on these. And so my concern is that the sustainability of these therapies in the long term is going to be based on will a hospital continue to be willing to provide these therapies if they're not receiving reimbursement for them. And so I'm not going to be able to solve that today. I don't know when anybody's going to be able to solve it, but it's an important issue. So what is the current status of immunotherapy? So there are 3 commercial products that I just mentioned. These are being used pretty strictly according to the FDA label that I went over. As you might imagine, off-label use is rare. Off-label use means that you have to convince an insurance company to pay for something that doesn't have an FDA indication. With these price tags, that's hard to do. And so that's the case. Now, what's really important are the investigational studies that are being done to try to expand those FDA indications, right? And that's, for CAR T cells, there's a number of different products with a number of different ways of trying to improve the CAR T cells. I won't go through the details, but just there are tons and tons of clinical trials going on in the US, in China, in other areas trying to improve on CAR T cells and expand the indications. For Blinatumomab, I'll get to that in a second. For Inotuzumab, we're starting to study that in children so that we can expand the FDA label to allow that. Again, I want to point out there's some limitations to Inotuzumab in terms of its toxicity and how we're going to incorporate it, but hopefully we'll get there. I want to spend the last little bit talking about what we're doing with Blinatumomab in first relapse, because I think this is the next horizon for pediatrics, is to incorporate Blinatumomab earlier and earlier in the disease process. So Anne mentioned that I'm chairing a clinical trial in COG, which is a major phase 3 study for first relapse of children with ALL. And I just briefly want to talk about the design of the study. So the patients receive 1 month of standard reinduction chemotherapy, and then they're risk stratified. And so the standard reinduction is basically the same drugs they received up front. They have lots of toxicity, and lots of the patients are MRD positive at the end of that. Not surprising. These patients have relapsed after receiving that same therapy. And so I'm going to get in a moment to what we're going to do to improve block 1. But as of right now, that's the standard. Patients that are early relapses or late relapses with MRD positive after that first block are on the left. They're the high risk. Patients that are late relapses with MRD negative at the end of the first block are on the right. Those are low risk. And what distinguishes the high risk from low risk is that one of them will receive a transplant when they get into remission, and the other one will continue to receive standard chemotherapy. So the question we're asking for the high risk is, if we replace these 2 blocks of chemotherapy with 2 blocks of Blina and then transplant, will survival be better? For the low-risk patients, what we're asking is, if we replace the 3rd block with Blina and add 2 additional cycles of Blina, will survival be better? So at the end of this study, which is about to finish accrual of about 500 patients, we should be able to establish whether Blinatumomab improves overall survival from an expected overall survival, a cure rate of about 45% historically in this group, so a lot of room to go up, and a historical of about 75% in this group. So we're powered to be able to answer the question whether Blinatumomab can help. I don't have the outcome data yet. I wish I did. I can't wait for them. But I do have toxicity data comparatively, and it's pretty impressive. So we've been able to compare the toxicity of the chemotherapy versus the Blinatumomab in the randomized arms. And in yellow is the chemotherapy, and in green is the Blinatumomab for the major toxicities that we see. The rates are strikingly lower in Blinatumomab. Because these patients have minimal disease at the time they're treated, the cytokine release syndrome and neurotoxicity have been very manageable, and the chemotherapy-related toxicities are simply not seen. So as tough as it might be to carry a backpack around for a month, these patients feel great. Their counts recover, their hair grows back. This stuff is very different than chemotherapy in terms of its toxicity. So the same pattern is seen with that next block of therapy. For the low-risk patients, the same pattern is seen. So chemotherapy, it may work better. We don't know yet, but we certainly know that it's more toxic. Hopefully, the Blinatumomab is both less toxic and works better in terms of cure rate. That's what we'll know eventually. And I mentioned that the AEs are actually quite manageable. All right, so I'm going to finish with mechanisms of resistance. What happens when this stuff doesn't work? Because it doesn't work every time. Right? We mentioned that the MRD negative CR rate with CAR T cells is 80%. That means that 20% don't achieve that. Why? Well, one thing that can happen even before a patient gets their CARs is that you can't make a CAR T cell product from your T cells. That's mostly a problem in young babies with leukemia and in patients that are very heavily pretreated. And so there are optimizations underway to try to collect the T cells earlier in therapy before our chemotherapy beats up their T cells so much that we can't make a CAR T cell, and improved ex vivo techniques to make the rate of success of creating CAR T cells better. Another exciting area is developing universal off-the-shelf CAR T cells. So as it is right now, it's an autologous product. You have to collect the cells from the patient, manufacture them, and then they come back to the patient. There are gene editing techniques that can knock out from a healthy donor's CAR T cells the antigens that cause immunologic rejection. So you could take a CAR T cell that was collected from an unrelated person, knock out the proteins that are going to make my immune system recognize that as foreign, and knock in the CAR T cell. It's called UCART19, Universal CART. So that's an off-the-shelf third-party CART that's being developed that could potentially make, it could mean that every pharmacy can have CAR T cells in the patient. Pretty exciting. But we're probably 5 years down the road to having that available. Now, let's say you get your CAR T cells. Some patients just fail to have their CAR T cells engraft, or they very quickly disappear. They don't persist. The optimizations that are underway to try to fix that problem are the use of better co-stimulatory domains. I mentioned the 4-1BB and CD28 earlier. There's potentially ways to even improve more on that. And there's other, there's fully humanized, there's co-infusion of antigen-presenting cells. These are all strategies to help that. Right now, about 10% of patients have this problem, where you give them the product, but the product just doesn't take off. And hopefully, we'll be able to reduce that 10% rate. Some patients, the CAR T cells get in there and they proliferate, but they actually don't get activated. This is a phenomenon that's known as T cell exhaustion. The T cells are there, they bind the CD19, but they just don't activate and kill the cell that they're binding to. And there's been a lot of work that's discovered the molecules, the signals that turn off those CAR T, that exhaust those CAR T cells. And the main ones are called PD-1 and PD-L1. Drugs have been developed that target those exhaustion markers and can reactivate exhausted T cells. And so one of the things that we have done is started to take patients who aren't responding to their CAR T cells or their Blinatumomab, which remember relies on endogenous T cells, and treat them in addition with one of these so-called checkpoint inhibitors. And that has had early success in reactivating CAR T cells and activating endogenous T cells when they appear to be exhausted. So this is really the next frontier in improving the response rates, the persistence of CAR T cells. With that in mind, the next trial we're going to do, and it's going to be led by Stacy Cooper, who's a junior faculty at Johns Hopkins, is going to try to improve. Remember I mentioned that block 1 of therapy we're using on our upfront, or our relapse study is really toxic and there's high rates of MRD positivity. Well, this is the data I'm talking about. On our trial, a quarter of patients treated with that first block have to stop being on the study because of toxicity. And despite that, they're still MRD positive. We have a long way to go for that initial therapy of relapse. And so what we're going to try to do is use Blinatumomab with checkpoint inhibitors as initial therapy for first relapse. So this, again, is potentially a paradigm shift. And what we're going to do in this study, I won't go into the details, but we're going to combine the Blinatumomab with a checkpoint inhibitor called durvalumab. We're going to first make sure it's safe, and then we're going to randomize patients either single-agent Blinatumomab or single-agent Blinatumomab plus the checkpoint inhibitor. Importantly, if patients get to a month later and haven't fully responded to the Blinatumomab, they can cross over and receive the combination. And so this is a study we're really excited about. It should be open in about a year, and will be open to all first relapse of biliary ALL. So look for it. Okay, the last thing I want to mention is antigen escape. So cancer is smart, too smart. If you just target one thing, it'll figure out how to not need that one thing anymore. And that's what's happening with these CD19 immunotherapies. What's happening is the cells are creating splice variants that splice out the epitope that the antibodies or the CAR T cells are targeted against. They're even keeping their CD19 internal and not letting it get to the surface. These are mutations that either pre-exist and are growing out under the selective pressure of 19, or the cells are acquiring these mutations as a way to escape this therapy. 40% of CAR T cell patients have this problem. 10% never engraft, 40% develop CD19 escape, 50% appear to potentially be cured. That's the numbers. And so if we could eliminate this problem, that would go a huge way to making this potentially a curative therapy for 100% of patients. The other thing that can happen is leukemias can switch their lineage. A lymphoid leukemia can become a myeloid leukemia, which no longer will express CD19. That occurs primarily in leukemias that express a certain genetic abnormality called MLL, but it can happen in others as well. All right, so one thing to note is that Blinatumomab, the incidence of 19 escape is much lower with Blinatumomab, probably just because it's less active, right? If the 1/3 of patients who respond to Blinatumomab, they're the ones that are at risk of CD19 escape. If you receive Blinatumomab and you don't respond, that's because your T cells haven't been engaged. You haven't put any CD19 pressure on the cells, and so there's no stimulus for a CD19 escape. And that's probably why when you give somebody Blinatumomab they don't respond, the chances that their 19 is going to be negative at relapse is much lower than if you give them CAR T. Hope that makes sense. So how are we going to address this? Hopefully with multi-antigen targeting. Just like with HIV virus or tuberculosis, if you use one drug, it becomes resistant. If you use multiple drugs at the same time to target multiple pathways, maybe you can prevent resistance. We're going to try the same thing with Immunotherapy. All right, let's see if you're paying attention. A 21-year-old male received an infusion of CAR T cells 3 days ago. He has fever, hypotension, respiratory distress, hypoxia, and edema. What's the most likely explanation? Yay! All right. True or false? The most effective treatment for CAR T cell associated neurotoxicity is tocilizumab. Excellent. All right. Which of the following are potential mechanisms of resistance to CAR T cells? Lack of persistence, CAR T cell exhaustion, clonal evolution or antigen escape, all of the above or none of the above. You guys rock. All right. So questions yet to be answered. Is immunotherapy going to be able to replace chemotherapy entirely in ALL? I think that 10 years down the road, we're going to give newly diagnosed kids with ALL a little bit of steroids, maybe a couple doses of incretin to debulk them a little bit, and then follow up with immunotherapy, and it's going to be cured. Maybe 15 years, but I think it's coming. What about transplant? Personally, I think that we will get to the point where bone marrow transplant will be a thing of the past for childhood ALL. I think we're there in a subset of patients already, potentially. The data have to mature, but it does appear that if a patient can get to 18 months to 2 years with persistent CAR T cells and not have a CD19 antigen escape, that those are potentially patients that will not have disease come back, even if they lose their B cells, their CAR T cells, and their B cells come back at that point. That's what the data that we just presented at ASH is showing, right? Now, you may wonder, a philosophical question. If I have a patient in front of me and I give them CAR T cells, and I know that 1 in 2 of those patients is potentially curable without transplant, should I transplant them all to prevent the 50% that might relapse? Or should I transplant none of them and only reserve the transplant for the patients who prove they need it? At Hopkins, we've taken the latter approach because there's no evidence yet that you lose anything by waiting for the patient to declare themselves as a 19 negative. And that makes sense, right? Because you haven't been giving them chemotherapy. They should be no less sensitive to chemotherapy after they relapse after CAR T cells than when they were before. And so you ought to be able to get them back into remission and get them to transplant if they prove they need. But this is a very controversial question, which we as a field are struggling with, and I know has been discussed at this institution a lot. Can immunotherapy be developed for other leukemia subsets like T-cell disease or AML? Maybe. Other cancers? Maybe. But the challenges are real. And the challenges are all about antigens and what antigens are chosen. Can these mechanisms of resistance be overcome? Maybe, but it's going to require research. Important question, can our medical system sustain the cost of these therapies as they become given to more and more patients? Where I really worry about that is in adult lymphoma. There are lots of patients with adult lymphoma, and now there's an FDA-approved therapy for it that's extremely expensive. It's going to put a huge burden on our medical system, and I fear that that's going to take away from the availability of these things for children with ALL, but we'll see. I'm happy to answer any other questions. Before I do, I want to thank a lot of people. First of all the patients and families who contribute to our research and our clinical care every day. Amanda Toll and her family for supporting this. It's so important, I think, to support these kinds of lectureships that get the message out there that things are getting better and that we're moving in the right direction. I have lots of mentors at COG and collaborators, a lot of them, Greg Riemann, Ann, Reuben, are right here. I have lots of mentors and colleagues at JHU, lots of Hopkins alumni here in the room, Jeff Dome, David Jacobson, Aaron Kim, Kirsten Williams, Deepika Darbari, Hema Dave, all trained at Hopkins and are here. And so we have a real link between our institutions, and hopefully we can maintain that. We have a great CAR T-cell team at Hopkins and my collaborators on NCCN. But please, any questions that you might have, and thanks a lot for listening. Yes, sir.
The cost of CAR T-cells are clearly a problem, and it's something that all of us are trying to address. But some nice, elegant models have been developed using quality of life or quality-adjusted life years and years gained and things like that. Have you compared the three different therapies you just talked about in terms of the quality-adjusted life years and things like that?
So I'm not doing that kind of research. I've been reading the literature, and what is the major comparison that I've seen is between CAR T-cells for ALL versus CAR T-cells for lymphoma. And it's about a five-fold difference where the quality-adjusted life years is five-fold higher when CAR T-cell used for ALL than when used for lymphoma. And so the argument is that that's really where the priority should be. Now, regarding the difference between let's say, it depends so much on the details, right? So if it's CAR T-cell without transplant, that would be one number. If it's CAR T-cells followed by transplant, that would be another much larger number. If it's Blinatumomab alone or with a checkpoint inhibitor versus Blinatumomab with transplant, I think the data need to mature for that. But all of these studies are coming with that very consideration, because I think we're going to have to make hard choices to prioritize these therapies, these expensive therapies, for situations where they improve quality of life and years of survival. I think childhood ALL is probably in the best position to be the highest on that priority, based on the results and on the studies that have been done so far. Carly.
Thank you, Pat, for that outstanding and informative talk. You mentioned about Blinatumomab and carrying a backpack. Mm-hmm. We've had a lot of experience where patients who need Blinatumomab, the home care companies are not approving it, and so they need to stay inpatient for the 28 days. Are you having that experience at all at your institution?
We're lucky in that Hopkins has its own home care institution, and so we can kind of tell them what to do rather than vice versa. But you're not alone in that problem. So I think that with FDA approval, that should be less and less of an issue. I think one of the big challenge we had with our study initially was that this was a totally investigational drug, it was an IND drug. And to ask a clinical home care company to care for a patient where they could become disconnected, where something could happen, and it's an investigational drug was a lot to ask. Mm-hmm. Most centers were able to deal with it, but not all. Now that it's an FDA-approved drug, I think it would be a home care company would be hard pressed not to create the capacity to deal with that. And hopefully this will be less of an issue over time. But it's absolutely an issue you're not alone for many institutions, and it's one of the logistical challenges that do have to be overcome.
Thanks so much.
Nobody's going to ask about transplant, huh? Do we have any transplanters in the room? Now's your time. Make your argument. Yeah.
I think a lot, going back to the paradigm that we had for MRD, so the way MRD really helped a lot, I'm sure the answer is going to be different for different patients. So I think really the most fruitful research is the one that says, what can we, when we initially are either like offering the CAR T-cell therapy or at some early time point after CAR T-cell therapy, we assess the patients to determine which ones are ultimately going to not need transplant, which ones are going to need transplant.
I'm really glad. Yeah. I'm really glad you brought that up. So you may wonder, how do we follow patients? So I mentioned that we do watchful waiting. Well, How do you watch when you're being watchful? So what we do is we do monthly peripheral blood for CD19. So what we know is that the loss of CAR T-cell activity is very clearly correlated very early on with the reemergence of normal B cells in the blood. And so if we start to see B cell recovery, loss of B cell aplasia within the first year, then we know those patients are going to need a transplant. The data are emerging that reinfusion of a backup CAR T-cell product doesn't work in that situation. It may be that checkpoint inhibitors may work to try to re-stimulate CAR T-cell activity, but until we have those data, I think those are patients that you want to capture them while they're losing their B-cell aplasia, but before they relapse. Those are patients that we think are great candidates for post-CAR transplant. The other thing we do is every 3 months, we send their bone marrow to a very specialized lab that can find CD19 negative ALL. That is not easy to do, right? And so you really need to send those samples to a laboratory that can gate on the right things to detect that small proportion of 19 escape cells before they can become a major problem. And we feel that by doing that, we're able to detect early enough an indication for transplant. But it's a great point. We've got to collect more data. And, the assumption we're working on is that we don't lose anything by waiting. We don't have data right now to show that. That's a leap of faith. So hopefully that will become. Thanks very much.